Hi, it's Thursday. Hope you're doing okay. It feels longer and longer that we're doing this. But anyway, I wanted to give you a short lecture on antipsychotics as I promised. And hopefully you read along with the slides when you're watching this, or after you see it, make sure and look at the slides to sort of cement it in for yourself. So antipsychotics, they're also referred to as neuroleptics. And I think I mentioned before, there's first, second, and third generation neuroleptics. The uses of antipsychotics is kind of interesting. You know, for the most part, we think of using them for a person who has psychosis, and certainly that's the case. For the use in schizophrenia, people are put on antipsychotics, and normally they remain on some type of antipsychotic. You might see the dose increased at times, like if that person becomes more acute or more psychotic, more delusional, having more hallucinations. Major depressive disorder, we've talked about before that somebody with major depression can have a psychotic feature that goes along with it. You may have seen that. To me, it's when someone has been depressed for quite a while. And if you think of the brain as an organ, it's like the brain certainly is overtaxed and might begin to create some other issues. Bipolar disorder, remember bipolar 1, the definition of that is somebody can have a have psychosis that goes along with that. Hypomania, mania, depressive, all being in a cycle and wanting to get to some stabilization. I also have down there that at times with PTSD, people can be psychotic. Generalized anxiety disorder, you know, you just think of overtaxing some of our symptoms and certainly can begin to have some non-real behavior or experiences. Tourette's eating disorder, which we'll talk about later in terms of eating disorder. And then I've seen it, and you would see it with acute agitation, and out of control behaviors. Someone that might be violent, you might need to sedate with an antipsychotic because they have especially the first generation antipsychotics have a big sedation component. And I would see people come into the hospital. I was the admitting nurse at Spring Harbor, and people would be put on doses of especially first generation antipsychotics, chlorpromazine, some of the others, haldol, with the desired effect of getting them to sleep and getting them out of this acute agitation, where they'd also display some psychotic features. So the big neurotransmitter here is dopamine. And we talked about that earlier. So again, you know, you're looking at the brain, the electrical component, as well as the neurotransmitters. So the thought being that there's an excess of dopamine in the brain. And so this kind of hyperactivity, and you can imagine impulses, electrical impulses going to different parts of the brain, you know, like maybe the temporal lobe. And so people are having trouble with speech. The frontal lobe, their judgment's way off, their occipital lobe, you know, you wonder if that's why people are seeing things that aren't there. And then in terms of the auditory part of the brain where all that function occurs, that there's a hyperactivity going on. So it can kind of make sense, even though it's very bizarre. So first generation antipsychotics are still used. Again, they can have a really nice sedation effect for persons who haven't slept in or antipsychotic or just really out of control. So one of the first ones, actually the first one that was ever discovered was chlorpromazine, thorazine. And it was first discovered, I don't know how they do this, the chemists, in the 50s, and it really changed the whole landscape of mental health treatment. Whereas people prior to that discovery would live in institutions for forever. If they were admitted and had a really significant mental illness, they would live there. There were many units in a hospital, kind of call them back wards, where staff mostly were kind of caretaking them and trying to do some treatment, but it was very difficult at the time. So fluphenazine, haloperidol, perfenazine are some of the antipsychotics that you would see. Haloperidol, unfortunately, I would see used because I did some skilled nursing care years ago. I would see that used for people when they were out of control and maybe used too frequently and too large a dose. And I think we're better at that now. I think we're understanding behavior more and certainly could recognize someone who all of a sudden seems psychotic as possibly a delirium. And we'll talk about delirium and dementia later in another lecture. Fluphenazine and haloperidol are helpful as well in that they can come in a depot, a shot. So people who are not good at taking their meds and or are so confused, if they agree, for the most part, if they do, because we talk to them about you won't have to take a pill every day, especially this pill, and they would come in and get a shot monthly. And we, in our outpatient clinic, there were psychiatric nurses that would give the injections. The next group is the second generation, and they have less side effects. And it's due more to they can really specify receptor sites in neuronal transmission. And some of the medications in that second generation you'll see on the slide is lorazepam. I don't know why that's up there at the beginning, but I would see olanzapine, quieptepine, risperidone used a lot, and ziprasidone, geodon used a lot. And then the other medication, and I need to add that because it's very significant, was clozaril, clozapine, and it is a remarkable antipsychotic. I saw people that were delusional for years, like in a state hospital setting, who would begin to take clozaril and clozapine and would all of a sudden, it's sort of like waking up from a dream where they would recall missing parts of their life. Or I remember this one fellow came and told us after starting on it that he remembered that he never went to his high school prom, and he was very sad about that. And we were like, oh my, I never was in reality, was always kind of saying gibberish, and we couldn't follow his thought pattern. And nice fella, he was really, he was very dear to us. But and that's the one, that can create the low white blood cells. So that's done very carefully. People have weekly blood draws sometimes, especially when they're on it early in when it's prescribed. And you're always concerned about their white blood cell count, so you want to check that frequently. And then what happens is once that lab study is reported to the prescriber, they may take them off totally if they're in jeopardy with a low white blood count, and or they might adjust doses if it looks like there's a little bit of a wiggle there. So, and then the third generation antipsychotic is real interesting. It's and I've got it on the slide. It's frequently used with an antidepressant to help stabilize mood, especially in a major depressive disorder. What's great about aripiprazole is it targets excess dopamine, but it doesn't eradicate all the dopamine in the body, so that many of the motor movement abnormalities don't occur with aripiprazole. So, you know, we've talked about a while back about first generation causing all kinds of motor movement side effects, tardive dyskinesia, akathisia, and some of the, you know, motor movements that are involuntary. So again, it would be mostly affecting the motor muscarinic receptors in the body. So with aripiprazole, you don't see those kinds of side effects. Now, you know, it's never not ever. Whenever I'm working with someone, and I might have mentioned, you know, somebody's put on a certain medication and they come back and say, I remember this one lady who was on valproic acid and telling us her hair was falling out as a result of it, and the physicians refused to acknowledge that this could happen with valproic acid, and but they took her off that, and sure enough, her hair no longer fell out. So people can have side effects, and you need to listen to them and say, wow, we should look into that. You know, we should think about that for you and what that means for you. So it's really important to listen to people. So some of the side effects with many of the antipsychotics, especially, you know, like those first heavy hitters, drowsiness, dizziness, sedation. You could see some restlessness, agitation, akathisia. You know, it can occur that you give a medication, for example, a benzodiazepine like lorazepam, and you want the effect of calming that person, or that person feeling more calm, less anxious, and in fact makes them more jiggy or more agitated, more anxious. So you've always got to be aware of that kind of, you know, and I can't remember the name, but it's like it has the opposite effect of what you're looking for. And I know you know that name. I'm sure Professor Hyde talked about it. Blurred vision could be another side effect. Low blood pressure, certainly, you know, a lot of times orthostatic hypotension, but we can see that too, where somebody really has a low blood pressure and or tachycardia, can have some cardiac ramifications. Geodon is one that, ziprasidone is one that can create, I think, an elongation of the ST segment of an EKG. So prior to anyone getting that medication, the physician, nurse practitioner would order an EKG baseline. Dry mouth, very typical, just seen with most everything. There's one exception to that. When we first started seeing clozapine used, clients would complain about drooling, excessive drooling, which was very embarrassing for them, and some people would not want to stay on it anymore because of that. Nausea, vomiting, constipation, you know, those just so familiar, so similar. Increased appetite and weight gain, we see that a lot with the second generation, where we see some real metabolic changes. elevated blood glucose and lipids and triglycerides. So those aren't unusual to see either. And then, of course, the more motor effects of the antipsychotics. The more, I put adverse effects here because when I was training, we would do side effects, like nausea, constipation, whatever, and then adverse effects being the more serious effects that someone can have when they're taking a particular medication. And I always liked that because to me it was like, okay, with a side effect, I can check with the client, I can work with them around helping them, be less nauseated, so on and so on, maybe changing the dose a little, but some of the adverse effects really impair that person's functioning and ability to have an okay life. Okay, so for some of the adverse effects, and I think you'll agree with me that some of these are really difficult and may warrant discontinuing that particular medication. So confusion, disorientation, severe agitation. So in other words, that'd be the opposite effect of what you're looking for. Pseudo-Parkinsonism. So people might, not knowing someone taking an antipsychotic, might think that person has Parkinson's because a lot of the movements and behaviors seen are absolutely similar to Parkinson's. So significant extrapyramidal effects because too much dopamine is blocked. Haloperidol and fluphenazine, prolixin, Haldol are the biggest offenders. And patients can present as if they have Parkinson's. So for you doing a differential diagnosis, you'd want to be sure of that. Cardiac rhythm disturbances, I think I mentioned prolonged QT interval, persistent tachycardia in terms of cardiac function. Especially, I think I mentioned ziprasidone. Acute dystonia. Now think of this, spasms of the tongue, the jaw, the face, the neck, the back, and it could look like this. And for the longest time, we thought that those kind of movements were part of the illness, when in fact the treatment of the illness was what was causing these different kind of really odd kind of motor behaviors. Kind of a shaking of the hand, similar to when you're looking at a lithium toxicity, you could see that. And then this kind of movement, and then pill rolling is another kind of movement that they talk about. I'm not sure I can do this for you, but so what happens with that is that person is so uncomfortable. So what the treatment of that is an anticholinergic, like benztropine or diphenhydramine, which is Benadryl. And so that we use that to kind of calm some of those extra motor movements that were going on. Tardive dyskinesia is a more serious kind of motor adverse effect. And I'm looking at the slide, it's involuntary movements around the mouth, lip smacking, unsteady gait, jerky movements, and they can be mild to severe. So sometimes the prescriber would stop the medication altogether. And sometimes I saw where, I know haloperidol, I would see this where that would start to present and the prescriber would actually increase the dose. Now, I'm not sure that's always the practice around tardive dyskinesia, but a lot of times it's taking that person off that particular med. Now, we see that a lot with first generation, and that's why it was so great when the second generation medications came along, because you didn't see those kind of abnormal motor pieces. And people, you can imagine, would be very self-conscious, wouldn't want to go anywhere, would be very embarrassed that these things were happening. And then there's neuroleptic malignant syndrome, and I'll talk about that in a minute. The slide here, and I did these slides, and I think that, I was meant to talk to you in person, but certainly can be life-threatening, neuroleptic malignant syndrome. So the next slide, talk about NMS. It's a life-threatening neurological disorder, most often caused by an adverse reaction to a neuroleptic or antipsychotic drug. So these are the symptoms that you would look for, especially, I would see, I didn't see this very often, but would certainly see it in the state hospital, where big doses of antipsychotics were being prescribed, because that person was so out of touch with reality and really suffering. But so what you would see is high fever, sweating, unstable blood pressure, stupor, muscular rigidity, and autonomic dysfunction, the whole parasympathetic nervous system. It says here too, and I note this, it can develop within the first 2 weeks of treatment with the drug, which would be, helpful if it's going to occur that, you put someone on that and you're monitoring them closely. However, the disorder can occur at any time. It's interesting because people taking anti-Parkinson's drugs can also develop NMS if those drugs are discontinued abruptly. And honestly, I am not as, I don't know if I'm an expert, but I'm not as aware of all the pieces about Parkinson's. And I know you'll be reviewing that with adult health. Certainly a difficult illness. So nursing considerations, here you go. So you're working in an outpatient clinic, or you're on a unit, or you're working with someone who is having a medical situation or is having surgery. For whatever reason, they come into your view. So daily mental status exam, certainly when they're acute and they're on the unit. Looking at their appearance, what's their speech like, what's their thought process and content, and what's their behavior like. Are you seeing a lessening of the psychotic behaviors, or are they more agitated, or how do they look now? Are they over sedated so they can't even move and they're sitting slumped over in a chair and drooling? I mean, obviously you would be concerned that they're getting too much of the medication. Sedating effect, especially in the elderly. Whoa. We really need to be so cautious using these. To me, they're heavy hitters and need to be so cautious in using with people who are frail and or elderly. So you really need to monitor for falls. And also, that same thing about get up slowly when you move from sitting to standing. As most of the medications for the mental illness, we do talk about that with people. Rapid onset of monitored blood pressure prior to and 30 minutes post parenteral infusion and or, I don't know about Depakote. I think that's in a more viscous solution. So you'd want to look at any increase in blood pressure when you're administering this in a parenteral injection. Or medication adherence is extremely important to prevent relapse. I think I mentioned before that, it's like, well, now why did you stop taking the fluphenazine? Well, what was that? Well, I thought I was feeling better and I felt better and I didn't hear those voices anymore. So, and so people will, it's almost like, taking an antibiotic, take it for 10 to 14 days and the infection's gone and you don't need to take it anymore. So people really struggle with that. You don't want to take a pill every day. Jeez, what a pain in the butt that would be to have to take something every single day. Avoid prolonged sun exposure. So, when people would go out on walks and staff would go with them, we'd want to be sure they had a hat and were using sunscreen because, wow, they can get burned really quickly. And people don't always get that. Take the missed dose as soon as that person remembers, but skip it if it's almost time to take another dose. And don't give extra, have someone take more when dosing because they've had a missed dose. So also you want to do some baseline monitoring. You'd want to look at their weight, their fasting blood sugar, lipid profile, and you would follow up every 3 months, 6 months, and year, annual lipid profile and monthly weights. Now, honestly, people that are on these medications may not be coming as often as every 3 months. So anyway, we do the best we can. That's what's encouraged. And the last slide is patient education, and certainly try to explain to the person what this medication should do for them, and that they should take it as prescribed, and you want to go over the instructions with them and stay on the medication. Keep all provider appointments, get all ordered labs drawn. Don't drink alcohol or grapefruit juice. I think there's a couple of the medications, I'll have to look it up, that you absolutely can't drink grapefruit juice. And I never knew that until a few years ago. So I'll have to look those up for you though, because there's a couple of that people need to avoid grapefruit juice. Monitor dietary intake. Certainly you got to watch their weights. You want to talk to them about foods high in carbohydrates. Drink plenty of water, eat vegetables and fruits. I mean, all of these things we should be doing. And especially educate people about the signs and symptoms of dystonia, tardive dyskinesia, and neuroleptic malignant syndrome. Now, when you're first talking to somebody and they're so psychotic and unstable, I mean, they're not really going to comprehend what you're talking about. But probably with the dystonia, they would get it, because, they're going to have more difficulty moving their limbs and not having tremors. And then tardive dyskinesia, a lot of times once people are on the med and they are more stable to be able to talk about that, and that there are medications that they can take that will help ease some of those side effects. Neuroleptic malignant syndrome, I think you really want to educate staff about that and caregivers about that. If a person lives in a boarding home or they're with their family, educate the family or primary provider in the family. Some of the people we see were newly diagnosed with schizophrenia, and families would really need to know about all these different side effects, because they would be the one seeing it and or able to do something about it. So that's it in terms of the antipsychotics. And I just want you to know I'm working on getting out a new outline syllabus, so to speak, for the next 6 times that I talk with you. And I'm also working on doing some unfolding case studies so that you would answer questions, and I want to do it in a multiple choice format to make it easier. And you would get those answers back to me in terms of the case study. So I'm still working on that. I know many of you could be anxious. I know I have periods of anxiety with all this, what's going on in the world. And, I try to do something else and talk to my family and call people and talk with my other children in other parts of the country. So I'm not meaning to add to your anxiety, and I'll be very clear about what we're doing. So you won't see a test similar to ExamSoft because I really think this kind of material lends itself to looking at a narrative and then answering some questions. You as the nurse, what would you do? What do you think about this? And I still need to figure out how many questions I want to ask for each case study. So what I'm thinking is, like, I do a case study for schizophrenia and have you answer some questions. Do a case study in terms of substance abuse, which is the next topic that we need to review, and so on and so on. And most likely get that case study out to you by Friday, and then have you submit your answers to me by Sunday at 11:30. So I'll be more specific. I know you want to know more. Really sorry how this is unfolding as well. I guess I'm trying to help you understand the material and not add to your anxiety. So anyway, I'm going to be working on stuff today, tomorrow, and all weekend, trying to push some things out for you. And again, write to me if you have some specific concern. Oh, I know too. I'm going to open up all the PrepU tests again in case some of you didn't do them and got a 0. I want things to be available for you. So if you need more time to do the practice tests, the ATI practice tests, I can open those up. We're not going to do the proctored tests because it just really wouldn't work. ATI is so tight on their, the way they need to be given and method and confidential and, all that stuff, and their copyright. And so we can't use that test. So I'm going to have to figure out another way to come up with a grade. And my sense is you'll all do fairly well doing the case studies. And you'll have a chance to refer to your notes. So, all right, take care. Watch a good movie. Netflix, Amazon Prime, Roku. They have a new whole thing. So, and again, if you have some ideas about something that's helping you right now, write to me and I'll get it out to everybody. All right. Bye-bye.